Thank you for the opportunity to share my experiences about lessons learned in developing and implementing a rehabilitation program for same-day total joint arthroplasty patients and our lessons learned. I'm Roland Peralt, a doctor of physical therapy and a member of the team at the McGivney Advanced Surgery Center, tasked to continually improve on this process. Since our implementation in August of 2018, for over 4 years, we've discharged many same-day patients successfully. Initially, in our discussions, we tried to eliminate can't from our documents. Precautions indicates something restrictive, and this negative teaching can lead to patient fear and anxiety. Our documents and our teachings attempt to use positive language to enable our patients to recover. In the total hip world, there's always been a focus on hip precautions, and the anterior hip approach helps to minimize many of those concerns. With simple, clear, plain language and a positive tone, we suggest things to do after surgery, as well as things to avoid. We clearly spell out our expectations for each patient. You should be able to walk normally with a step-through gait. That means putting one foot in front of the other. You should be able to use an appropriate assistive device to achieve that goal, and so on. Of course, there are positions and activities to avoid and behaviors to endorse, as well as behaviors to avoid. Things like don't overdo it, perform activities in short, frequent bouts rather than, trying to run a marathon, and so on. The key difference for our McGivney successes have been, 1, we have therapists always available when the patient is ready. Timing is always a challenge, and it isn't always economically sound. 2, DME is available for the home discharge. If we need rolling walkers, a cane, etc., we have them available. 3, all educational materials are reviewed with the patient and the family member, and we check for understanding. 4, OT performs bed mobility, dressing, getting dressed, as well as bathroom use. Number 5, physical therapy performs mobility. We do walking, stairs, exercise. We transition the patient to the next level of care, which typically for us has been to proceed to home care, which has already been set up. And the last thing is we utilize a solid home care approach. We have a home care agency that we try to use consistently because they're a good partner who understands the goals and the objectives of our program. Our discharge criteria are quite simple. Pain management plan is in place, and the patient identifies on the visual analog scale a level 3 out of 10 or less, that they're able to void, that they understand the weight-bearing precautions, that they're independent with transfers, with walking with an assistive device, and with stairs as needed, and that they also have a clear understanding of the home exercises and other discharge instructions. Any DME that's required is ordered and provided while in the center. And one of the key things is that the patient needs to have an escort to home. It's not sufficient for Uber to pick up a patient. So we do need to have somebody there to escort them to home and to stay with them. Barriers to the same-day approach include the timing of cases, especially cases that are later in the day, like the surgeon's 3rd or 4th case of the day. Nausea is often a barrier, usually anesthesia-induced. Dizziness could be medication-induced, or it could be a medical problem. And the inability to void is usually caused by that saddle anesthesia that they get from the spinal block. And the last thing is with knee replacements, sometimes we have buckling knees, and that's usually induced by a very ambitious peripheral nerve block where you got some motor involvement. From a recent presentation I attended, provided by a leading orthopedic hospital, their response to each of these barriers were as follows. Late cases. Only first cases or early cases were considered for same day. Nausea. Most often they were admitted because we can't wait around. Dizziness. Again, most likely admit for the same reason because of the timing. An inability to void was almost automatically an admission. And the knee buckling was also an admit. Our belief at McGivney is that the cases are scheduled and planned for the same day, and we should consider all of these patients regardless of the time of the day and regardless of the barriers that come up. With nausea, we would communicate with nursing and then try again later. Sometimes that might take a few hours between trials. Same with dizziness. An inability to avoid requires patience and periodic walks and cooperation between therapy and nursing to allay the patient's anxiety over that issue. And the dreaded knee buckling is the one that we must never, ever, ever frustrate the patient with. Often that, we offer that they could stay or that they could go home, and that this is a perfectly, normal reaction sometimes to a nerve block. We explain that with a knee immobilizer, they could achieve all of their mobility goals and go home. And they're often relieved to know that they could do that, and that once the nerve block would wear off, they could be cleared for discontinuing the immobilizer by the home physical therapist. Of course, all of that gets communicated with the home care agency if we were to discharge with an immobilizer on. So all of these barriers, if there's any concern that arose with either the patient and or the family member, we were always prepared to admit the patient since we're connected to main hospital, but the number of times that an admission would occur per year, I could count on one hand. The economics of staffing for same-day total joint discharges can make for a very long day for the provider, with some gaps in their schedule. But it's critical to have PT and OT present at all times during the recovery of our patients. As with all aspects of the process of caring for the ambulatory patient, from the pre-surgical preparation, the anesthesia, the operating room experience, and the recovery, there will always be opportunities for improvement. It has been one of the greater challenges of my career, assisting with the development of this program and in sharing this information with you. May you find even better processes going forth. Thank you very much.